Now I'm going to talk about recurrent abortion. Recurrent spontaneous abortion, also known as recurrent pregnancy loss, is defined as 3 or more consecutive losses of clinically recognized pregnancies prior to the 20-week of gestation. However, it is important to note that this does not include ectopic, molar, or biochemical pregnancies. Also, the incidence of recurrent spontaneous abortions is 0.4 to 1%. And then risk factors. Ultimately, these risk factors are included for any type of spontaneous abortion. However, it is important to note that unfortunately an answer cannot be determined in about 50% of the cases. But other risk factors include uterine factors such as fibroids, immunological factors such as the case with lupus patients, endocrine factors, genetic factors, thrombophilia, and fibrinolytic factors. Also, environmental chemicals and stress can ultimately contribute to recurrent spontaneous abortions. And some other factors that are included are personal habits, infections such as pelvic inflammatory disease, the male factor, and a decreased ovarian reserve. Just also to highlight a little bit about the evaluation of a patient with recurrent pregnancy loss. History and physical is key with these patients. During your history, what's really important is you need to get a description of the gestational age and characteristics of all her previous pregnancies that resulted in a spontaneous abortion. Physical, it's not just important to do a pelvic exam, but you need to do a thorough head-to-toe examination, as this can lead to other systemic issues that may be causing the pregnancy loss. In terms of diagnostic tests that also can contribute to finding the underlying cause of why a patient may be undergoing recurrent spontaneous abortions include a karyotype analysis, a detailed uterine assessment, your anticardiolipin antibodies, or your lupus anticoagulant. Also, it's important to get hypercoagulable states, such as your PT and PTT. Thyroid functions are also important, and the evaluation of ovarian reserve. In terms of the management of these patients or couples undergoing recurrent spontaneous abortions, it is key to either, if an underlying mechanism can be determined, to treat that or manage that underlying disease. However, in about 50% of the cases, as I mentioned earlier, there's no reason for recurrent pregnancy losses, and these can still be a chance of a live birth is actually still positive. Over 50% will undergo a live birth with no intervention.
Another complication that we have to worry about is septic abortion. It's basically a spontaneous or induced abortion that's also complicated by pelvic infection. Infection usually begins as endometritis, which is inflammation of the endometrium, and it can also progress to involve the rest of the products of conception, which can include the placenta. The causative agents are usually E. coli, gram-negative, GBS, and chlamydia and such. The most common complication is PID. And then it's also the leading cause of maternal mortality in the third world. This is basically because in the third world and other developing countries, medical practices are not as well established. So in that case, a lot of these are performed illegally, and they're performed without the proper sterilization techniques. So in the U.S. and Europe, which the Western world basically, the incidence of septic abortions is 1 in 100,000. The treatment for this is IV intravenous doxycycline and sulfoxetine.
Okay. Discussing the risk of spontaneous abortion, a woman with a history of spontaneous abortion, that's a very important factor in increasing the risk. With one previous spontaneous abortion, the woman has about a 20% chance of a repeat spontaneous abortion. With 2 previous spontaneous abortions, the risk increases to 28%, and with 3 previous spontaneous abortions, it goes up to 43%. In addition, preterm delivery, you have an increased risk of preterm delivery with the history of spontaneous abortion. And finally, second trimester pregnancy loss is significantly associated with recurrent second trimester loss in future spontaneous preterm birth. And to conclude our presentation, the main points that we want to get across include spontaneous abortion is the most common complication of early pregnancy. Significant risk factors include advanced maternal age, previous spontaneous abortion, and smoking. Most spontaneous abortions are due to structural or chromosomal abnormalities. The most common presentations that you see in the office setting are amenorrhea, vaginal bleeding, and pelvic pain. And ultrasound is the most useful test in evaluating the type of spontaneous abortion that's occurring. And recurrent abortion is defined as at least 3 consecutive spontaneous abortions. And finally, septic abortion includes a spontaneous abortion that is complicated by pelvic infection. And we'll finish off with a few board-style questions. The first one, 24-year-old Asian American woman comes to your office for her 3rd antenatal checkup at 12 weeks gestation. She says that she is feeling well for the last 4 weeks because she no longer has nausea and vomiting. She also says that her belly is not enlarging like before, indeed it is decreasing. When you ask about any vaginal discharge, she says that she had mild dark brown discharge 4 weeks ago, but it stopped spontaneously, and that's the reason she didn't think much about it. On examination, the cervix is closed and fetal heart tones are not heard. Real-time ultrasonogram reveals a collapsed gestational sac with absent fetal heart motion. Urine pregnancy test is positive. Based on these findings, what is the most likely diagnosis in this patient? Now, since she had thought she was pregnant and there was a delay of about 4 weeks before finding out that the fetus is no longer viable, we would consider this a missed abortion. The reason it's not a threatened abortion is because the fetus is not viable and no longer the fetal heart tone heart rate was not measured. Complete abortion involves discharge of tissues of conception, which has not occurred. And inevitable abortion, again, you would at least have some sort of fetal heart tone, and in this case, there's no fetal heart motion. Next question. 32-year-old woman, G2P1 at her 18th week gestation, comes to the emergency room complaining of vaginal bleeding. On examination, fundal height is consistent with dates, fetal heart tones are heard, cervix is closed, and mild vaginal bleeding is noted. ER ultrasonogram shows a normal appearing gestational sac and normal fetal heart activity. She denies any injury to her abdomen or use of any drugs. Her medical history and her first pregnancy were without any abnormalities. Her vital signs are BP 128 over 80, respiratory rate is 14 per minute, temperature is 37 degrees Celsius, pulse rate is 76 per minute. What is the most appropriate next step in management? This is typical presentation of a threatened abortion. A patient before the 20th week of gestation presenting with vaginal bleeding, and as was already discussed earlier, you want to treat this with expectant management. So you want to provide reassurance and outpatient follow-up for this patient. That concludes our presentation.